It's my distinct pleasure to introduce our speaker today. This is Dr. Christopher Sperring. He's well known to many of us in CWIS, but not all of us. He's been a member for a couple of years now, but let me just give you a brief bio. It's pretty impressive. I'll have to truncate this a little bit or we won't have time for his talk. But he spent some early years in Chicago working for a nonprofit. He's trained at multiple universities around the world: Göttingen, Germany; Cape Town, South Africa; Cornell University in New York; the Charité Hospital in Berlin, and he's also trained in Zurich. He works in Göttingen, Germany now at the University Hospital and has been there since 2010. He has multiple roles. He wears lots of hats. He's an orthopedist, but he also works as an emergency doctor and travels on the air ambulance. And he's also studying at the Lufthansa Aviation Training Leadership opportunities, the head of the German Road Safety Council, and is an expert in traffic medicine. He's on the executive board of the German Society of Trauma and Emergency Surgery, and his current academic position is the senior consultant at the Department for Trauma and Emergency Surgery, Orthopedics, and Plastic Surgery at the University Medical Center of Göttingen. I was going to say something funny about he doesn't yet have a Nobel Prize, and he's a slacker in that regard because 47 Nobel laureates have either trained or lived or done something with Göttingen, which makes it the most Nobel city in the world. And maybe Chris can tell us a little bit more about that association. But anyway, welcome, Chris. Very excited to hear your talk.
Thank you very much for the introduction. I'm quite far away from a Nobel Prize. I'm not putting any energy into trying to win a Nobel Prize. But what is nice about Göttingen is that it's a small city, but it's quite a good place to be creative and develop new ideas and work on change management. But at the same time, it's a place where it's quite difficult to implement new things. And I talked to you guys about my work at the Lufthansa Aviation Training Center, which is the Human Factor Academy, training pilots and also other health professionals in leadership and in communication and interpersonal competences. And in this regard, I talked to you guys about the problem of implementing chest wall reconstruction as a new treatment option in Germany, and as it is already implemented in your country as a standard procedure, and also in some other European countries, it's very, very hard to implement that in Germany. And that makes it quite important to talk about change management. So how do we get this chance of treating patients in this area into a change of the whole spirit of orthopedic trauma surgeons, also thoracic surgeons or general surgeons? Can you see my first slide? Is it visible?
Yes.
Okay. So I just start with the talk about change management. And in all this regard of change management, it's important to ask yourself, where does this opportunity or this willing to change come from? So I start with the case. Some of you have seen this case already, and I just want to share this case with you because it's one of the very early cases where I learned that it's not that easy to just do something new. So it was this crane operator who was sitting in his cockpit, and he fell off this cockpit. You can see that on the right picture, and was stabbed by one of those poles. When the helicopter brought him to our resuscitation unit, he arrived in this situation. So he had an open wound of his chest wall. It was quite far open, and he luckily missed the heart and also the pericardium, but all the rest was quite heavily injured. And I guess, every one of you can think about, okay, what would be the next steps now to take care of this patient? I would like to tell you what the German approach would be. There would be no one taking care of the chest wall. They would do early debridement. They would take out like all the debris from the steel pole. They would lavage the pleura room. They would maybe put some vacuum sealing on it, which is quite a good way to do it. It's like a damage control approach. But the problem then would be this patient would get a pneumonia, this patient would get even sicker and sicker, and there would not be a way, not a window to operate on this patient. Even if someone would want to do some chest wall reconstruction, there would never be a window, or would not be a window before the next, let's say, 5 to 10 days. And that might be too late for this patient. So then they would maybe, get some inflammation, and at some stage it would be, with a 60-year-old patient, quite hard to get him to survive this injury. And then everyone would say, well, it was an open wound, huge open wound, high velocity injury. We couldn't save them all. I don't know, this is maybe, just storytelling, but it's, I guess it's kind of reality in many centers. And I wouldn't like to accept this. And that's why I started with chest wall reconstruction in about 2008. And we put plates on ribs, which were thicker than the ribs themselves. And we didn't do very good for these patients because we really made this thorax stiff. And then some new implants came up, and we really learned a lot by treating these patients. But until today, which is now it's about 16 years ago when I started, I'm still the only surgeon taking care of these patients. And this is one part of a not successful change management. So I want to talk about this change management, and I'm trained from Lufthansa, and you can see that this is my colleague Cordula, who flies the A350, and she is one of the captains who train the other captains, and they have to go to this cockpit, this training cockpit in Munich, twice a year. Every Lufthansa pilot has to be there twice a year to get their license for another half a year to be allowed to fly this A350. If you imagine that in medicine, being in the OR, imagine there would be like a surgeon showing up and every half a year would say, well, I'm here to check if you can still do your surgery. It's not in our mindset. And what they train and what we train at the Human Factor Academy is technical, procedural, interpersonal competences. So you have to know your machine, you have to know the procedures, how to communicate, and you have to also know what and how to deal with your colleagues. And the same now we apply it for medical situations. It's technical, procedural, interpersonal. It's the same. So talking about this, why do we need change? Looking into medicine in Germany shows us that 100,000 relevant malpractice a year occur in Germany. And of these, 19,000 patients die due to this malpractice. I don't know the numbers about the United States. I guess they are quite even higher, but it's 19,000 too many people. And if you look into an A350, this is one of those guys. It's one crash each week. And Lufthansa would not exist more than 1 week if these planes crash every week. So why do we need to talk about communication? Looking into these patients, they travel quite a lot before they even reach the hospital. And while working at the hospital, you need systems, procedures, and technical machines and operators to get these patients to survive. 17% get transferred even to another hospital and start the journey again. So communication is quite important. We know that 50% of significant malpractice occurs in trauma resuscitation, and 70% of the complications occur due to in-house interfaces. And we know that 120 people, oh, sorry, there's a misspelling, 120 people work on polytraumatized patient within the first 24 hours. So this is human factor training. Human factor training is about safety, it's about interpersonal competences, and it's about situations that are dynamic and complex. And we have to take care of these situations. This is the basis for safety. Lufthansa says, well, of course they say that safety is part of our DNA. What they want to reach is a safety aim of 10 high -8, which is the maximum of one crash in 100 years. How about in Germany, in medicine? We are far away from this safety aim. And we know that about 80% of critical incidences in aviation and even more of critical incidences in medicine are due to human failure. So we need to talk about technical procedure and most important interpersonal competences, especially if we want to change something. There was this Amy Edmondson from Harvard University who wanted to know, so now if we want to change, if we want to work in teams, do we do more mistakes? Do we make more mistakes if we have a good functioning team? And what she found out is improved team performance results in psychologically safer teams. And that's why the numbers of mistakes increased, because they were now not afraid anymore to talk about their mistakes and to report their mistakes. So we can only learn from those mistakes to really change something. But for this, we need psychological safety within our team and within our organization. I want to give you this example, which you can check in your own department and in your OR, whether this would work like this. So the Kathmandu approach has a very special approach because the plane has to be on a high altitude. This gray line is supposed to be the altitude of the plane because there's a big mountain, and if they're too low, the radio control from the tower cannot reach them. So in this case, the captain was too low, and the first officer said, "Captain, I'm very worried we are too low." And he said, "No, don't worry, I've done this 100,000 times." And then he said, "Well, I can see the river. We are absolutely too low. I'm very worried." And he said, "Oh, no worry. Don't worry. It's okay. We are fine." And then they were almost crashing. And after a couple of call outs, he said, "I take over control." And in this situation, the captain has to put his hands off and gives the control over to the first officer. The first officer went back to altitude, landed the plane safely. And when they landed, the captain said, "Thank you, and I'm sorry." And now imagine in the operation room, you're making a mistake and your assistant doctor says, "Well, you're making a mistake. This is not correct." What would you say? I mean, you wouldn't say, "Okay, you take over control and finish the surgery." And it's quite interesting to see that this mindset of teamwork and working together is so far away in medicine. And it's maybe even closer in your country. In Germany, we are even way further away. So now talking about change management, talking about this chest wall, how do you get chest wall reconstruction as one part of a very important treatment option in Germany implemented? Why at all is it necessary to manage and orchestrate a change process? I said I want to change the management of chest wall injuries. So I changed it and I said, now we don't do A anymore, we do B now. And I failed. So what we say is, and what we know is about 70% of all change attempts are not successful. And that's why we need this process. We needed to orchestrate and manage the process of change. And why does it become relevant because we have to talk about values, habits of employees, the DNA of the organization, the important why, how, and what, and procedures that are already out there. We have to be aware that these can be supporters, but they can also be opponents. So there are three reasons for major changes. One change is an acute crisis. You all know the last huge crisis was COVID. Suddenly everything had to change. Organizations, companies had to change from now to like next second, to have people working on remote, to have people wearing their FFP2 masks, to change their office setting to have more distance and all that stuff. So there can be change that's externally triggered and it's an acute crisis, and you really have to promote that, but you also have to make sure that the people like fulfill these rules. So it's all about communication, and it's also about to get these people informed so that they not do like anything weird, something weird when you're not looking or not checking. There are also external factors like mega trends or innovation. Like mega trends is now all the electric cars and that stuff, the electric mobilization. I don't know if this is successful. I think they're not doing a good job in change management regarding electricity and mobilization. I think it's they just try to put this in onto the market with huge amounts of money and not very much management skills, but it's still an external factor, and it's a mega trend because it's the whole world going in that direction. But it's also internal factors. Could be that in your company that some doctors are leaving, or the head is leaving, or like we're facing now the demographic changes in Europe, having most of the people going into retirement and really getting a lack of workers in the hospitals. To answer these different ways of external or internal factors that need you to react and showing a need for change, it's the magical triangle of change that you always need to keep in mind. There are three important parts of your organization. Your organization, which is the white triangle, is like sitting or hanging in this triangle. And so the strategy of your organization is doing the right things. The structure is doing things right. And you have to keep in mind the culture that you are having in your organization, the common horizon of meaning, like your values and that stuff. So as soon as you change one of these parts, the other two triangles will also change. So you have to keep in mind that these three dimensions never are able to be changed in a single way. You always have to change all three of them. And that means you have to catch your employees to also change culture, meaning, values, and understanding of your strategy, of your structure. Otherwise, you will fail with your organization. And looking at the change itself, there's always the view of the organization create structure so that people can change. That's the part of the organization. But there's also the part of the individual. We have to accompany people so that they want to change. And we can ask ourselves, do we want to change? Why do 70% of the changes fail? Because everyone wants a change, but who wants to change? And I think this is quite important to understand, that it's not comfortable for people to change and to get into this process. So we have to navigate those teams through the change process. And how do we navigate them? So this is the situation now. First of all, we have to unfreeze procedures, algorithms, and to put them into the very raw material. And then this raw material, the DNA, we change in this raw material, we move them to a different stage, different area, and then we have to refreeze them because otherwise they will not function. And the successful moving is characterized by involvement of the employees and their aims and objectives. So in this part, moving algorithms and moving procedures, you have to involve your employees and your coworkers. There's an 8 steps change process, which was published by Mr. Cotter. And the first one, he said, everything starts with creating a climate for change. So you have to identify the need. Why do I need to change something? Why does something needs to be changed? And then you have to create the spirit and the climate. You need to find supporters within the team and within your employees. And you have to create a vision together. So in this very early stage, it's not your idea. It should not be my idea to now start chest wall reconstruction. I need to create a vision together with the rest of the team and also the head of the department. And then the next step is to get employees involved. So get them active, mobilize employees and others and friends and whoever for them to develop their own ideas, remove barriers, let them identify why this change could be a failure, and let's remove the barriers together and highlight small successes. Like, you have done this chest wall reconstruction and the patient is well off, extubation next day, going home after 2 days or 5 days, doing well. I mean, this is a huge success and let's celebrate that. And then the next and the last step is sustainability. And I think this is maybe the major part why at the end change processes are not successful, because you have to hold up the pace and then create sustainable structures. And in the whole area, during the whole time, you need to be transparent in your organization so that everyone always know what you're doing. It's not you're doing it, it's the whole organization. And keeping that in mind, you can draw this influence and interest stakeholder matrix, which is important to understand the part who to and how to involve which employee in which stage of the change process. So they are the guys who have low influence and low interest. They are quite hard for you. They are the guys who have low influence but high interest. Those are mostly the young, unexperienced assistant doctors. And then there are the guys who have high influence but low interest. Those are your opponents. They're hard to get. And then there are the guys who have high influence and high interest. Those are the guys who are your promoters, and you really have to pamper them to get them on your side. And now you can choose your employees and your friends and whoever, your team, and divide them into this area and say, okay, who's where? And how do I need to talk to whom in which way? So the guys who have low interest and low influence, you need to supervise them. The guys who are your opponents, you have to satisfy them. The guys who have high interest but low influence, you have to inform them, keep them informed, keep them up to date, and support them. And the guys who are on your side, you have to manage them to multiply your strength and your point. So getting back to that patient, the guy who was stabbed, we went to OR right away, took care of the wound, and this is just day 1 after the surgery. He did well. He was still extubated by that time, but then we intubated, but then we extubated them just an hour after that. And he was doing fine, and he was discharged after a week, doing very well. We did the wound healed. You see the summarizing again, and we did a body plethysmography, seeing that there's no significant problem in his lung function. So with this 60-year-old guy, even after 3 weeks, he was doing well. I went and tried to inform the guys who were my opponents. I tried to show all the evidence also from Chest Wall Injury Society coming up in these years. And then we tried to set up some clinical pathway to always have the transparency in the way how we treat, how we indicate, and how we do the reconstruction. And also we try to implement objective measurements for the right indications, when to do surgery, which thorax and which chest, and how many ribs to fix. We also did some research on the timing of surgery, which is the rapid, early, and late onset surgery. We also did it with our patients and with patient group from 3 departments in Germany, and try to somehow of like convincing the German society, and slowly they started to change. And there was another patient, this patient, who got stuck in her car. You can see the heavy displaced rib fracture. And I was not there. And the consultant on call, he called me and said, "Chris, you have to come here. We have to do this." And I said, "Well, why don't you do it?" And he said, "Well, I've never done this before and I don't know how." And so I went there and did it with him together. And he was so on fire after that, because this patient was treated like there were all these stabbings of the diaphragm and the liver and the lungs, and we took care of all this, and the patient did very well, and was discharged quite early. So he said, "Well, let's look into what is after cardiopulmonary reanimation." CPR, and you can see we now started doing the CPR also during the CT scans, and you can see how much the chest wall gets compressed in this area. So we started to put up an algorithm for these patients after CPR, getting also the chest wall reconstructed so they can breathe autonomously, so without the respirator. So it was another guy, it was like a promoter on my side. The problem was he was not very influential, but he was absolutely on my side, and we started to do some of these surgeries together, develop different techniques to reconstruct those post-CPR patients, and always checked in the body plethysmography. So I think what is important to be transparent at all times, to be communicative at all times, and most important, to hold up the pace. Because if you look into this 8 steps again, if you lose your pace, if like in the 200th patient, your chief surgeon and director says, "Well, there's no indication because we haven't done this for 30 years. Why should we start doing this now?" You have to start the whole process again with a single person, but you should hold up the pace. Otherwise, you will lose. And then you have to create the sustainable structures to really be successful in this area. And one of these successes is the, as Sarah said earlier, the Göttingen chest wall reconstruction course, where we train on cadavers, and we have very great international support from the CWIS. You can see people, this is another director, a couple of senior consultants and assistant doctors and students taking part, and also, investigating and being really getting motivated to get deeper into this topic. And I think this is the success that we need to celebrate, but also create sustainable structure like this course, and just keeping this up for the future. And I want to end this this talk about change. This is from the US patent. I don't know what is Patentamt in English, but it's one of the first drawings of a car. And it's so interesting to see that the first drawing of a car, so a vehicle moving without a horse, still would have a wooden horse head in front, because they could not imagine that anything would move on the street, not even looking like a horse. And they even said it's injury prevention, because when a horse would pass, it wouldn't realize that this is not an animal. So it's crazy when we think something absolutely completely new, we still stay in these old structures. If you want to change something, we need to dare to dream, and we need to trust commitment, passion, enthusiasm. We need to put all these values together because already Socrates said, the secret of change is to focus all your energy not on fighting the old, but on building the new. And you have to think really absolutely new from the very start. And I think Lufthansa is not maybe one of the leading airlines in the world, but what they do and what I really like about them is that they are very open with the communication of mistakes and changes they want to put into reality in their company. And the last one I want to cite is Gottlieb Daimler. He said, in the future, there will only be 1 million cars on the world because the number of chauffeurs is limited, which is quite interesting view on the cars. If you imagine that Tehran is relaunching 1 million cars each year, and then the former CEO of IBM said there's a world market of perhaps 5 computers. So, just put yourself into that view and that position and think about what already changed, but maybe also what has not changed so far. And I think that's something we really need to consider. And when we want to change something, it's only working if we orchestrate a whole process. Thank you very much.
Christopher, thank you. That was a very inspiring talk. It's clear that you have taught yourself to be an expert in this change paradigm or process. How are you going to translate this to your colleagues in Germany who, have an interest in doing this, but may not have the motivation or the connections that you have? Is it as simple as inviting them to a course and showing them that it works and then offering your support later? Or what's the mechanism for having other people do what you've just done?
So we thought about this after the last course we did in last fall. And I think one of the major tools we can use is a mentoring program, and not mentoring only on the medical and the technical and the procedural side, but mentoring these people for another year in orchestrating the change process. So what we want to do in the next after the next course, we want to put the change process as one of the topics of this chest wall injury course, and then offer them a mentoring program of experienced guys to just, be on their side while trying to change this process within their, or changing the algorithm within their hospital. I think you can only be successful if you really want to change something, and when you are successful to get your team involved. And for that, you need support from someone who is experienced.
I don't see any other questions, so I'm going to ask another one. So, CWIS has no shortage of practitioners who want to affect change. I mean, it's probably the primary motivation for people to join the society and get involved, is that they want to start doing this. They want to improve this process for their patients. And we've never really we've discussed and we've played with mentoring ideas, but heretofore we've basically been we focused on education and advocacy and those sorts of things. But can you put your thinking cap on and tell us how you think CWIS could evolve to become better at change management with our members? I mean, I think we do a great job, and we have various programs. We're doing great work, and I don't want Sarah to get offended. But I mean, how do we take it to the next level so we actually are actively involved in getting more people to change their processes?
Well, I think you guys are you're the reference in the world for chest wall reconstruction. I mean, if anyone in the world needs technical support and procedural support, looking in your guidelines, looking in your research, and looking like in the way how you treat patients. They can join the webinars, they can join the case discussions. But what they always learn is that someone is really good at this. So now I want to be good at this as well. I can learn, I can go and study, I can even do some research on it and whatever. But how do I get this change within my department started? So there was a phone call 2 weeks ago on a Saturday. One of the guys who heard a talk earlier of me, and he called me and said, Chris, you have to help me. There's an absolutely unstable chest wall, and I want to do surgery on it. So this guy is not even a consultant. And I said, well, I can offer you, I can come over to your hospital and we do the surgery together. All you need to organize the material and you need to organize the OR. And he said, well, that's not a problem. So he organized the material, he organized Synthes to get over to his hospital and put the matrix ribs system there. He organized the OR. So now Monday morning came and he wouldn't call me back. So I called him and said, what's going on? And he said, well, my director said, we haven't done this for 30 years. We will not change this. So he gave up. They didn't do the chest wall reconstruction. They put a chest tube in there and the patient died 2 weeks after that of pneumonia. And I mean, I don't know if this is a mistake, but it's absolutely not the way that we want to go. So the problem is not the technical support, because it's there. It's there with CWIS as well. You have the mentoring program as well. You have all the research, you have all the guidelines. But we, like in Germany, we always say you have to put the PS on the street. You have to put like the power on the street to get the car moving. So, we have all these abilities now. But if we really want to change, then we really have to support our promoters, or even the ones who are very interested but don't have a high influence, to help them to spread the spirit within their department. And I think this is much more on an interpersonal part. That's why I talked so much about the human factor, because this is the human factor. Why would a director say, we haven't done this for 30 years, plating ribs? Who plates ribs? You have to change this person. It's a personal problem. It's not a medical, it's not a research, it's not an objective problem, it's a personal problem. And we have to deal with these interpersonal issues.
I think one of the barriers, and you spoke to it and certainly understand this, but I think it's worth restating, is that your process, your curve, your 8 steps, the problem is that recognizing the need oftentimes comes after a case. There's a case that needs the need and didn't get it, or got it and it went poorly or whatever. So it's almost out of, how do you build the perception that change needs to be before the change can be initiated? See what I mean? It seems almost like it's out of sequence.
I think you are successful when you have an idea, when you want to change something. And I made this mistake in the beginning as well. I said, I want to change something because the way we do this now, and I do this now, is not good. And always talking about I do this is not the right way. We have to build up the team in the very, very, very early stage, and then promote them to create their own vision and let them dare to dream. I mean, they should create their vision. And once they have their vision, they want to follow this vision, and they will be promoters of your own idea.
Yeah.
And I think, when you get this team involved, and this applies not only to people who are in the hierarchy below you, but also in the hierarchy above you. So now my director was all crazy about chest wall reconstruction, because he got all these phone calls from other hospitals all over Germany and said, well, you published something about chest wall reconstruction. You have this guy in your department who does this. I have this private patient. What can I do? Can I transfer him to you? So he was all crazy. No problem. You can transfer to me. I'll take care of it. and then he called me and said, Chris, you have to take care of this guy. And so he took on this change. And that was the second when I celebrated, and I said, I realized, okay, this is now sustainable, because now the spirit in this department changed.
Well, are there any questions from the audience? You can unmute yourself and ask, or you can type it in. Sarah, you always have some interesting insight questions.
I'm having trouble with my camera for some reason, so I can't turn it on to be, directly asking you this question. But I think, well, I guess I should say what I know of your practice environment is that there are specifically challenging cultural issues in Germany and Europe, overall. But I know you've also had practice experiences in New York and Chicago within the United States. Do you feel like it's more or less challenging, in the environment you're currently in, or from times, obviously you weren't doing chest wall injury surgery when you were here in the United States and you were in training, but just based on the cultures that you've seen, do you feel like change management, is that you have a harder time in your current practice environment than what you were seeing when you were here in the United States?
Well, there is a lady in Coburg in Germany at the university who has who is a professor of change management. So I think in Europe we have a huge need of change management because we
Yes.
are having a hard time with change. To be honest, when I was in Chicago in this Jewish Council on Urban Affairs, this nonprofit organization, I felt like you guys have a culture of being very, very open for new ways and new ideas, and you are very much willing to take them up and to change up to a certain point. And then I felt like most of the people pretended to change and pretended to change their behavior, but in their heart they didn't change. Because human beings like to be in their tradition and always
Stability.
They like what they know.
And it's always something uncomfortable to change. But I love this little slide where you ask who wants change, and everyone says yes, and who wants to change, and no one says yes, because it's it's always
Yes.
hard to change your own behavior. And I think, to be honest, change process and change management is absolutely necessary all over the world, and it's only in a very nuance different in different cultures, because human beings are human beings, and we do not like to change.
I think that's a very astute point. I think your point is well taken, that people think they want change, but they want change from others, not necessarily from within themselves. So
No, and you guys are very open. You're much more open for change.
that's very true.
And you guys
That's
are
very true.
Change is like
very much faster taking this up and saying,
Change-
well, yeah, I'm absolutely there with you. I do marathon from tomorrow on, and all that stuff. It's
Yes.
but then you have to understand that you also have to change your nutrition. You also have to change your getting up in the morning and run when it's raining and all that stuff. And suddenly
Yes.
people say, "Oh, I didn't want this."
Right.
They're still a marathon runner, and they like this, and they're absolutely enthusiastic about it. But then they say, well, it doesn't really fit into my work schedule and that stuff. And in Germany, it's more like, they start thinking marathon. Oh no, I don't want. Yes, it would be cool, but no, I can't realize. And so they think so much, and then they would never start.
Sure.
And that's why we need this in Germany. You don't need the first 5 steps in your country. You can start at the step 5. In Germany, we need to start before step 1.
Yes, we're a little more, leap and then look, and you guys maybe
Yeah.
think it out a little bit better. That's possible. I
think
can
it's like
appreciate
any
that.
other human behavior. It requires practice. I mean,
Yes,
if you've had
I
successful
think that's
change
true.
experiences, then you're more likely to be willing to try something else to change, so.
And that's why you need the transparency. If you're transparent in all what you do during this change process,
Yeah.
the people will see that you as a team are successful. It's not you yourself, but it's the whole team being successful. And that's what can convince them.
I see that Dr. Satori is on the line. David's from Hungary. Hello, David. How are you?
Well, I have one more question while you're at this. So, have
Okay.
you been corrected? You talked about, in a surgery, what would happen if someone were to correct you or needed to step in? Do you invite your OR team to then, have you taken this the next step to practice this change management, to invite your OR team to then correct you if they see something? How does that work? What's the dynamic?
So this is two different things now. One is the human factor part that we train with the communication, safety culture, threat and error management, and all that stuff. And within that is these call outs and takeover control. It's still hard for me to have like an assistant doctor on my side and having him say, I take over control, because I know he wouldn't be able to do this. But what I really enjoy is I did the reduction of a very complex case the other day, and I was all crazy about the reduction. I said, well, it's an anatomical reduction. I'm very happy. And I felt like he was not that crazy about it. So I asked, what do you think? And he said, well, that's okay. And I was like, geez, what's wrong with you? And he said, well, why don't you try this and that? You haven't tried this, and I think you can do better. And I was like, in my brain was like, okay, should I ask him if he wants to leave? Or should
Your head was about to explode. Yeah.
So I said, well, no, I'm Lufthansa trained. It's okay. So I involved him and said, well, tell me your 5 steps how to reach the goal. And he said, that's this, and this. And I said, well, okay, do you want to do it? He said, no, you do it. So I did this and it was better.
There you go.
And,
very
and I said,
good example of practicing what you preach. I like it.
Yeah, so I said, thank you. This is teamwork. And I mean, it's always a different part of perception. And, just yesterday I did an acetabulum fracture with my director. And there's one very difficult screw to get in there. So that's not in the joint and in the nerves. So he tried to get the screw in there, and I was very tired because I worked all night before. So I put my head against the X-ray machine and was kind of falling asleep a little bit. And he said, Chris, what's up? So, well, nothing. So you're doing good. So he tried and didn't get it in. And then he said, okay, I think now it's your turn. You do it. And he really wanted to do this surgery. So I went over, I put the screw in, it worked out, it was no problem. It took me a couple of seconds, not because I'm better than him, because I have not tried for half an hour. I was like fresh in that situation. I had the chance to to watch him doing this. I had the chance to see what he's doing wrong, and I could put all this together and do the right movement. And it was just one tiny little millimeter different that I did differently than him. And he was like, yeah, you sometimes need the different perception. It's true.
It's fantastic. I like it.
Let me ask David. David, anything in Chris's talk that struck you as important as you are blazing the trail, so to speak, with rib fracture repair in Hungary?
Yeah, my situation is really similar in Germany, and it's a really big gap in the chest wall treatment, because it contains too much bone for a lung surgeon and too much lung for a trauma surgeon, and it's absolutely an empty field. And my idea was to to call the young surgeons, the young and beautiful nurses, of course, to make a team together. And it's really hard to figure out how to spice up the team. Guys, you are able to save lives. You are able to do this. You can be a better surgeon. Please join my team. I would like to teach you. I would like to offer you a future to be a great surgeon, and you are able to do it alone. I'm your supervisor, and you can do a lot of things. Now I'm on duty, and I had an interesting case 3 hours before, a really polytraumatized patient with a right side nephrectomy, splenectomy, a right hepatolobectomy, and a terrific chest wall rupture, diaphragm rupture, dislocated bones everywhere, with really big hemorrhage, not only in the abdomen, in the retroperitoneum, and in the thorax as well. And it's really nice. We made a team because now I have 3 juniors and they were with me and we made it together. And I think they would like to join not only the CWIS for my team as well, and we can work together in the future because this is the moment what we can offer to the juniors. Please join in me. We can do it together. And after that, you are able to do, I'm your supervisor, personally or online, what you want. And please tell to your colleagues, it works. We are able to save lives. You are able to save lives. Tell another colleague, and I can travel to your hospital and teach them, and that can, after beginning at circus with CSS process. So I think it could work. But the first 5 steps is really hard. I don't have boss. So because it's an empty field, there is absolutely nobody who can control me, who can stop me. So it's easy in my hospital, but outside my hospital, it's a very big problem. Who this fucking shittery from your and why would like to treat the chest injured patient? Hungary is a really small country. Everybody know everybody, but yes, it could be a big problem. Now our plan to make a course how to treat a chest injured patient and teach the trauma surgeon how to suture the lung, how to control the bleeding, and teach the thoracic surgeon what mean osteosynthesis and angle stable system. And under the CVS umbrella, I think it can work. I got a lot of idea, and in Berlin, we can talk in personally how to manage this course. And I think it could be universal first in Europe, because the problem is similar in European countries, different in the United States. So we can work together with Chris and a lot of great guys. Yeah, that's my opinion.
Thank you, David. It's clear that you are an agent of change, and you're motivated to do that, which is really the primary ingredient. It sounds like, Christopher. If you don't have that, you don't get anywhere. So you got to have a change agent. So thank you so much. We're over time here. It's been a great session. Sarah, do you have any announcements for the viewers? Do you want to? You kind of did that at the beginning, I think.
Yes, just a reminder that next Wednesday at 12 o'clock Mountain, we do have Journal Club with Dr. Serrani. So keep an eye on your email, and then also this will be recorded, and you'll receive a copy of the recording if you want to share it with any of your team members, and then it'll also be posted to our website. So keep an eye out, and thanks for joining.
Thanks, Christopher.
Thank you.
Awesome. We'll see you
Have a
soon.
good one.
Yeah.
Okay.